I am Ohmagari from National Center for Global Health and Medicine in Japan. I'm going to talk about current status and issues related to COVID-19. Since I'm a clinician teaching patients, I'm going to talk about the clinical setting and the human health. To start with, let's look at the current status of COVID-19. Please note that this is the data as of November 28th. So on November 28th, at this time point, we had 2,510 patients in Japan. March-April is considered as first wave, July-August the second wave, and we are in the midst of the third wave. Unfortunately, we cannot see the decline of the number of patients. As clinicians, so we sincerely hope to see the decline in the number of patients. Let's look at the clinical picture of COVID-19 in general. In short, there's such a broad range of severity. Some people are very mild and some people suffer from severe disease. That's the general clinical picture of COVID-19. Really, majority of people end up with disease which is very mild. Some people are really asymptomatic. That's the clinical natural course of COVID-19. 80% of the patients are cured with mild disease. It's rather difficult to distinguish it from a common cold, but there are some differences that we should be aware of. In case of a common cold, usually 3-4 days after the onset you see the symptoms. The typical symptoms include running nose, cough, and sputum, which is a pulmonary symptoms, and then you have throat pain. They all come at the same time. This is a convenient way of diagnosis that I think you should keep in mind. These all come together in common cold. And in case of a common cold, the symptoms peak on day 3 to day 4. And then gradually these symptoms are relieved and most people are cured within 10 days. That's the clinical course of a common cold. Exception is that you may have some viral infection like RS virus. Then you have sustained cough for about 2-3 weeks. In case of COVID-19, you have much longer sustained period of symptoms. If you have a fever, you may continue to have a fever for 2 weeks. You may have a running nose for a longer sustained period of time with the sustained fatigue. That's a feature of COVID-19. Usually the symptoms last for about 2 weeks. When you actually hear what the patients tell us, they say it's different from a common cold, that they've experienced anything like this before. They never had a fatigue like this or they couldn't eat. That's what they say. So it's different from common cold. They have sustained duration of symptoms and they suffer, among some people, very strong fatigue. And here it says that 20% of the patients develop pneumonia requiring oxygen. If you take CT or X-ray, some people have mild pneumonia, although it seems like a mild cold, but only 20% require oxygen. But these numbers, I think, are lower nowadays because these numbers are based on the Chinese data as of January, and these tests were taken place in those days with those with the severe symptoms. So it seems like we have a relatively higher percentage of people requiring oxygen. Currently, if you look at all the positive patients, maybe it's around 5 to 10% of the patients develop pneumonia requiring oxygen, or close to 5%. Having said that, a disease requiring oxygen with pneumonia in 5% of the patients is something that you cannot find in other disease, so you have to be very careful about COVID-19. In case of influenza, it's not that 5% require oxygen developing pneumonia. What happens is that usually during the first week, patients remain mild, but after a week, usually between 7 to 10 days upon onset, people worsen. They have severe cough, they become breathless, they become too tired to walk, they have higher fever, and they develop poor conditions of breathing, respiratory failure requiring oxygen. What should be noted is that during the first 1 week, there are many people with mild symptoms, and suddenly they feel fatigued or they become breathless, unable to move after exercise, and they develop pneumonia. So you need to keep in mind that such things could happen. A few require artificial ventilation because of poor respiratory function. And this percentage is also lowered nowadays, but according to data from Tokyo, 1 out of 100 positive patients, or 1% of the people, require artificial ventilation in COVID-19. It's true that many people are mild, but there are some people who develop severe disease, so we really need to be cautious about the condition. This is the patient who had the severest disease that I have actually treated in February. I have a permission to take this photo. He was 63, he was on Diamond Princess. He developed fever. He was suspected of influenza, but he was negative for influenza. He was diagnosed as COVID-19. On day 7, he was transferred to our hospital. His condition didn't improve upon admission. On the second day, he had high fever, couldn't eat, he had vomited, and the following day, he had a respiratory failure. He required oxygen. He worsened, and on day 10, he required artificial ventilation. But that wasn't enough in terms of oxygen, so he was on extracorporeal membrane oxygenator with the blood taken out of the body. With the supply of oxygen, the blood was returned, and he was on ECMO for 3 weeks, which was a long period of time. He must have suffered greatly, and he recovered. And 1 week later, he was off artificial ventilation. So he was on artificial ventilation for a month. And this fact really weakened his body. All his muscles were weakened, and it took time for him to rehabilitate. He was wasted away from the disease, and he was discharged after 3 months and returned to the States. Can say is that this is a typical example of a severe COVID-19. You really have to suffer from a long period of time. Medical practitioners have difficult time, but the patients, the family, and all people related to him really have a great suffering. We need to be mindful about the fact that this is what we are facing. A story like this is not generally known to the public, so the horrible thing about COVID-19 is not well communicated. Some people may be okay, but there are some severe cases like the patient that I just explained. Another problem with the COVID-19 is the variety of symptoms. Particularly well known nowadays is the loss of taste and smell. This is the first report from Italy. 33.9% of the patients suffered from loss of either taste or smell. It was the first report given. And these appear in the acute phase, but they are sustained to be seen in the chronic phase. In the acute phase, you have these symptoms, but another problem with COVID-19 is that you have sequelae. That means the symptoms are sustained for a long period of time, making patients suffer. This has become a global challenge. And this is called a long COVID, and this is the patient survey we conducted at National Center for Global Health and Medicine in Japan. It's the chronic complications of COVID-19. You can see as on the right you have cough, and then you have dysgeusia, dysomia, dyspnea, fatigue, and sputum. And it shows the proportion of these symptoms. In case of cough, you have about 60 to 70% of the patients suffer from cough earlier in the acute phase. They are relieved that some people suffer from cough for as long as 200 days. In addition, a loss of taste and smell is seen among 40% of the patients, but the frequency is lowered, but sometimes people suffer from as long as 150 days. These chronic sufferings are now seen in COVID-19. Of course, the degree of severity varies, but some people suffer greatly for example, fatigue that make people depressed and unable to go back to work. So we really need to treat these people and make sure that these people will no longer have the sufferings. If we have more positive patients, there will be more people suffering from these symptoms. Entire society need to tackle this problem. It's not that once you get infected, it's over. It could be a sustained issue, and I need to remind you of that. We were also shocked about alopecia. This is the data from our patients. 24.1% on cumulative basis suffer from alopecia from one time or the other. And sometimes it lasts 450 to 200 days. In case of severe infections like dengue or SFTS, which is a zoonotic disease, sometimes we see severe symptoms when you have viral infections leading to alopecia, or like the symptoms I mentioned in long COVID, like fatigue. Perhaps there is a common mechanism of action among these diseases. One of the things we learn is that sequelae extends over a variety of organs in the body. Pulmonary function is particularly important as it is directly related to our activities of daily living, and here's a report from the Netherlands. 124 cases were looked into, average age is 59, 60% were male, and there are a variety of patients from mild to severe. 42% of the patients who were discharged had less than normal pulmonary diffusing capacity, and 99% of the patients had normal CT lung image, and 93% of the mild patients had normal chest X-ray. But a higher proportion of people suffer from lung conditions and symptoms, and this is a problem. 91% of the patients discharged had the pulmonary function abnormality. As a result, what happens is that 22% of the patients have lowered exercise capacity, 19% of the patients have lowered lean body mass index. That means muscle mass is reduced. So most likely because of respiratory functions and less muscle lead to a reduced exercise capacity. To our surprise, 36% of patients suffer from mental function and cognitive function related problems. This was our surprise. When you have a severe infection, when they go to ICU, some patients suffer from these conditions. This also is applicable to COVID-19. The health conditions is generally poor. 64% have functional disorder, 69% have fatigue, and 72% have reduced quality of life. So COVID-19 really has a great impact. Let me now talk about therapy. When I talk about therapy, I divide patients into three groups. Those who have no respiratory failure, those who doesn't require oxygen, those who have respiratory failure with oxygen requirement, those who have a severe respiratory failure with artificial ventilator. There are three stages of therapy. First is antiviral drug. Most people, even if they have replicated viruses in the body in 1 or 2 weeks' time, they can get rid of the virus, but some people cannot do that. Then there will be lots and lots of viruses that cause infection to many cells, leading to severe disease. Those who could become like that, or those who are already in that condition, then antiviral drug is used to stop or prevent the replication of virus. Remdesivir clinical trials were underway globally. Number of days required to the recovery of symptoms compared to placebo was shortened by 5 days. Time for the recovery in condition was shortened by 5 days, and the drug was approved for these indications. There are other promising drugs under study. Another treatment is the blood product treatment. Blood donations from the recovered patients are used for plasma therapy, or recovered patients have antibodies against COVID-19. Clinical studies are underway to use these antibodies or antibodies similar to them. In particular, those with the mild to moderate patients, they respond well to these possible therapies. And then you have immune modulators. When you have virus replicating all over the body, that causes the cell death. And leukocyte is recruited, and as a result of that, you have immune disturbance. As a result, a strong inflammation is seen not only in the lung but in all parts of the body, causing death. So we need to suppress immunity. Dexamethasone is known to reduce the fatality, so it is used as the standard of care. In addition, there are other immune suppressors under study. Anticoagulation is another therapy. In case of COVID-19, blood can be clotted easily, so we have anticoagulant used for the therapy. So we have come to get more knowledge about the therapy. We have much expectation for vaccine. For the interest of time, I'd like to go through this very quickly. Traditionally, a part of the virus or the entire virus are used with non-pathogenicity, which are called inactivated vaccine or live vaccine. The feature of the new vaccine under development is that genetic information of virus is incorporated into the body. The nucleic acid would synthesize protein, and that protein related immunity is prepared. Messenger RNA and virus vector vaccine are under development. There are vaccines in phase 2 and phase 3 with promising efficacy with these features. So including these new vaccines, we will have much expectation as there are many positive implications to the society, but since this is new, we also need to be mindful about the safety. Now, when it comes to what's happening in COVID-19, let me share with you some of the data that we gather in Japan. Kobe-Reiji is the data that is gathered by hospital doctors. This is the precious data. We serve as a secretariat, and I'd like to share with you this data. This is the number of patients. Pink is the severe cases, blue is non-severe cases. The left is the first wave and the right is the second wave, and as you can see, in the second wave we have less number of severe cases. The age is often quoted as the reason behind this. The red is the second wave and the blue is the first wave, and the horizontal axis shows the age groups of the patients. The peak age of the patients in the first wave was between 50 to 59 years old. The peak age for the second wave is between 20 to 29, so there are more younger people in the second wave. Since younger people have milder disease, we have less severe cases and less fatality in the second wave. Whether that was the only reason, I'd like to discuss that later. It's true that we have better prognosis and better mortality, but there are some other differences, and this is the data I'd like to share with you. This is the number of days required from onset to hospitalization in the first period up to June the 5th. Average was 7.6 and median was 7. Later, after June the 6th, the average was 5.1, median was 5, so we were able to shorten the number of days required for hospitalization by 2 days. This is due to the improved medical system and the improved awareness of the people. Early discovery leads to early diagnosis and treatment, and I believe that this also contributes to the better prognosis of the patient. Also, the severity on admission. We look at the proportion of severe cases on admission. On the left is the first wave, and the second wave is on the right. For fair comparison, we have stratified patients into age groups. In the age group of age over 70, the severe case risk was 48.4%. In the second wave, it is down to 34.6%. This is hospital mortality. We only compare severe cases on admission. Those above the age of 70, before the June the 6th, the mortality was 31.2%. This is down to 20.8%. Those between the age of 50 to 69, it was down from 10.9% to 1.4%. There are various reasons mentioned. At least in the second wave, we have much less mortality. Hopefully, we see much less in the third wave. Infectious control is often very important. Avoiding 3 C's, I think, is very well known in a closed space with the close contact. When you speak without a mask, this is a very high risk. Everyone can take actions to avoid such risk, and this is well accepted in Japan. People have higher awareness about the importance of risk control and infection control. This may be the reason why we have less patients in Japan than in Western countries. With that in mind, WHO Western Pacific region has prepared the campaign of avoiding the 3 C's and prepared a poster. Another thing that surprised me is that in UK also the campaign has been prepared for 3 C's. Professor Jonathan Bantam is a well-known figure, and he mentioned this in his article. And in UK, we have a lockdown situation in early December. Administrative measures as well as individual measures to avoid infection is very important, and this is the reason behind this 3C campaign, I believe. The nasty thing about COVID-19 is that asymptomatic people can infect others. The highest risk exists when you are right before the onset to infect others. It's troublesome for clinicians. Normally, we control infection by controlling people who have respiratory symptoms, but that doesn't work for COVID-19. This has become a very severe issue in the clinical practice, and came the idea of wearing a mask. Evidence was gathered to see that when in medical practice, if everyone wears a mask, there was less infection. Western people are not favoring masks. It was not popular to wear a mask, but even in these Western countries, because of this evidence, and because the universal masking was mentioned in the famous journal to wear a mask even you are asymptomatic, and this has spread to the world, the concept is important that you have to wear a mask even if you are asymptomatic, and we were able to practice this in the medical practice, and this has become a major progress. 3 C's and a mask, they are important, but some people prefer some more concrete examples. These are the examples shown by researchers at Disease Control and Prevention Center. For example, if in a karaoke establishment, you have a higher risk of infection if you stay there longer. Infection risk is higher if you are not wearing a mask in the karaoke establishment. In a small karaoke establishment where COVID-19 didn't prevail, most of the customers wore a mask. Consequently, we were able to show some recommendations as to stay shorter time period and wear a mask when you use these services. It's easier to understand better when you have these concrete examples, and this is a part of the progress we see when we learn more about COVID-19. There are several topics I'd like to share with you. What this shows on horizontal axis is the persons aged 75 years among confirmed cases. Vertical axis is case fatality rate. There's a linear relationship. What I'm trying to say is that when you have higher proportion of elderly patients, there's higher risk of case fatality rate. In case of Japan, now it may be close to 15%, but as of October 28th, it's 12.7%, and fatality on cumulative basis is 1.8%. So Japan is below this line. This is thanks to the efforts of all Japanese people. But without measures against infection, there will be a higher proportion of elderly patients, leading to a higher case fatality, which is very clear. So we really need to work very hard to prevent the elderly people from getting infected in the society as a whole. And for that, we need the collaboration from the younger people to prevent the spread of the infection. There's one bright news. We are now about to be able to predict who can develop severe diseases. This is the study by Dr. Sugiyama and Dr. Mizukami from our National Center for Global Health and Medicine. We now know that those who could become severe have lower concentration of CCL17, which is a cytokine. When we monitor these patients, we learn that before they develop severe diseases, 3 values of proteins, including interferon lambda 3, go up. By monitoring these values, we can identify who could become severe and when they could develop severe diseases, and we can provide timely therapy. And if we succeed, we can reduce the number of people who suffer from severe diseases, and we are all working hard to apply this in a clinical setting. This is my last slide. Pandemic has a major impact in the society. Not only that, there are other impacts, which is written in this paper. It says COVID-19 is not a pandemic, it is a syndemic. Syndemic is a word that combines synergy and epidemic. I think it means there is an interaction among different diseases. Increase in COVID-19 leads to the delayed diagnosis and treatment of various diseases. You have less diagnosis of tuberculosis. You are unable to diagnose cancer, including lung cancer. As a result, there are more people suffering from these diseases where they visit doctors only they become serious or severe. So it's a health issue. But you also have other problems like increased alcohol intake, increased suicide, and increased domestic violence. These are social issues secondary to COVID-19. We should not just look at COVID-19, but we also need to deal with COVID-19, keeping in mind there are secondary issues. But for that, we need to suppress, contain COVID-19 as early as possible. That's very important. The very basis for everything to be resolved is to control COVID-19, and it is to control infection. That is what I want to emphasize. With this, I'd like to end my talk. Thank you very much.